Welcome, doctors. Today's lecture focuses on surgical protocols for dental implant placement. Our primary clinical objective is to systematically optimize both aesthetic and functional outcomes in our patients, transitioning from foundational theories to specific, actionable surgical and prosthetic frameworks. Let's begin. When managing complex aesthetic zone cases with 3 to 4 adjacent missing teeth, achieving an optimal outcome requires strict adherence to specific surgical principles. We accomplish this through 3 strategic pillars. First, the strategic placement of only 2 implants to support a multi-unit fixed partial denture, FPD. Second, the use of narrow-diameter implants, NDIs, specifically for lateral incisor sites. And third, the routine use of local contour augmentation via guided bone regeneration, GBR. Our first surgical principle is what we call the rule of 2. To maintain biological stability and avoid compromising the interproximal bone, implant density must be limited. If a patient has 3 missing teeth, we place exactly 2 tissue-level TL implants to support a 3-unit FPD featuring a central pontic. For cases with 4 missing teeth, we implement the Geneva solution, which means placing 2 narrow-diameter implants, NDIs, exclusively in the lateral incisor sites. In these scenarios, there is also a clinical preference for utilizing hybrid design implants to further enhance soft tissue stability. Our second principle addresses the inevitable biological reality, bundle bone resorption. Routine local contour augmentation is absolutely essential to counteract this resorption and address underlying soft tissue deficiencies. Surgically, we must extend our bone augmentation into the future pontic and cantilever areas. This involves both horizontal and vertical augmentation to properly optimize soft tissue height. If, after healing, a vertical deficiency remains clinically unacceptable, we compensate prosthetically through the application of pink ceramics. Let's examine how this looks in practice. This clinical case study demonstrates a successful 10-year aesthetic and functional outcome utilizing our early implant placement protocol combined with contour augmentation. Surgically, we utilized a mixture of autogenous bone chips and deproteinized bovine bone mineral, DBBM, particles beneath a collagen membrane. The patient successfully transitioned from a provisional acrylic restoration to a definitive metal ceramic FPD. Most importantly, the 10-year post-operative CBCT scan confirms a highly stable buccal bone wall, validating our regenerative success. The longitudinal data objectively validates these surgical principles. In our prospective studies spanning 5 to 10 years, we observed a highly stable regenerated facial bone wall. Specifically, we recorded a mean facial bone thickness of 2.2 millimeters in a study of 41 patients with TL implants. Furthermore, across a 10-year period involving 20 patients with bone-level BL implants, we achieved a 0% dropout rate. Remarkably, 95% of these patients demonstrated a fully intact facial bone wall at their 10-year follow-up. We must also recognize that protocols shift when moving out of the anterior aesthetic zone. In the posterior mandible, where we see a high frequency of implant placement at 76.6% in premolar and molar sites, GBR procedures are frequently required but governed by distinct anatomical constraints. Due to predictable buccal bone resorption in this area, there is a strong clinical recommendation against type 1 immediate placement. Furthermore, surgical safety demands a precise, preoperative analysis of the mandibular canal and lingual undercuts to prevent severe neurological or hemorrhagic complications. In conclusion, predictable long-term success is dictated by strict adherence to biological principles and specific surgical techniques. For two-wall defects, you must employ a simultaneous GBR application using a 2-layer composite graft technique. This means packing highly osteogenic autogenous bone chips as your first layer, and protecting them with a second layer of slow-resorbing DBBM. Finally, remember that for soft tissue optimization, the adoption of an 8-week healing period prior to early implant placement has been our established clinical standard of care since 2009.